Good afternoon, everyone. My name is Michelle Niehaus, and I am the Program Administrator for Deaf and Hard of Hearing Services at the Kentucky Department for Behavioral Health, Developmental, and Intellectual Disabilities. And I am thrilled that we are now participating in our second of a series of 4 webinars addressing substance use disorder in the deaf community among people who are culturally deaf. So today is going to kind of be our flu edition because a few of us who are presenting or talking to you are struggling with voice and coughing and sneezing, so please excuse extra sounds that happen along the way. But we will be sharing a lot of information with you about the impact of language on access to and use of treatment. So I'm going to pass it on to Melissa to talk about our funding and how we got started today.
Hello, everybody. My name is Melissa Witham, and I am here representing the Opioid Response Network. And Opioid Response Network, otherwise known as ORN, is sponsored by the Substance Abuse and Mental Health Services Administration. And we support organizations and state agencies that are supporting individuals with a substance use or opioid use disorder, and we provide recovery, treatment, and prevention related technical assistance. And technical assistance is sometimes giving resources and information, and at other times supporting events such as this and bringing together experts from different parts of the country to educate audiences such as yourselves on different topics relating to better prevention, treatment, and recovery supports. And each state has a designated person who receives technical assistance requests and helps to identify the best experts to help bring that information to the requester. And if you would like more information about the Opioid Response Network, you can visit our website or email us or give us a call. And if you would like to request technical assistance on behalf of your organization, you can do that at the website as well. Thanks, Michelle.
Thank you, Melissa. And we are getting ready now. You get to see our fantastic presenters in just a second. I'm going to first commend those of you participating that you were able to answer both of our polling questions, that the responsibility of ensuring effective communication with deaf individuals and the interpreters is only the interpreters is absolutely false, and that using written documents during individual or group sessions is a good substitute for having a qualified interpreter present. So we have 2 experts in the field who are going to talk about why these are not good substitutes and why it is the responsibility of everyone in the room to make sure that effective communication is happening. Many times people think that putting an interpreter in the room solves all the problems, and it doesn't. We all work together to ensure effective communication and effective treatment. So today, your very qualified presenters will be Deb Guthman from Minnesota. She helped to establish the Minnesota Chemical Dependency Program, which is the longest running substance use treatment facility in the country with specialized deaf services. And Jesse Wilson, who is seeing the challenge and the stress of establishing a new program in San Diego. His program is booming, and he is serving people in the San Diego area for aftercare and for housing. So I'm going to turn it over to Jesse and have you all get started. Thank you so much for being here today. And Jesse, if you can take it on.
Hello, everyone. My name is Jessie Wilson. I'm a CADC 2. I'm a certified alcohol and drug counselor here in California. Also the program director for an outpatient and aftercare treatment program in San Diego. I'm happy to be here. Welcome, everyone.
And
go ahead, Jesse, and get started with the slide 1 that's up.
Oh, where are the slides? One moment.
one of the first things for us to think about is what many hearing people don't know about American Sign Language. So Jesse, if you could kind of talk to us a little bit about American Sign Language and some of its factors that impact how a person who is deaf receives information, that would be really helpful. I can go through the key points, and then if you want to elaborate on that, Jesse, then that would be great. Some of the key points are that American Sign Language is not the same as English on the hands. A lot of times a hearing person will say, I want you to sign exactly what I'm saying, and that's impossible. There's a wide range of ways to sign something and ways that that can be receptively taken in. Clearly, American Sign Language is a very visual language. It's also nonlinear. In English, we talk word for word. I am going to the store. The signs, however, are almost like painting a conceptual picture. They're nonlinear, and it would be signed more like store. I'm going there. So even with a qualified interpreter present, it's the provider's responsibility to ensure that effective communication is happening. Jesse, are there some points? Oh, go ahead, Deb.
Oh, this is Deb. I was just going to add one thing. A couple other things to remember, because I'm assuming some of you may have worked with a sign language interpreter before. And if you're listening to what the interpreter is voicing, sometimes you may think, wow, that response doesn't match with the question I asked. So one thing to always keep in mind is if you're not really feeling like the information matches, it's okay to restate what you heard, which will then have the interpreter interpret the information you've said to the person again. And the person may go, wow, that isn't what I said. And then you may get a better response from them. Or on the same token, you may realize that that particular client isn't understanding the question. So you may need to ask it in a different way. So remembering to really listen and pay attention and not assume that everything that the interpreter is saying the client said is exactly accurate. Really follow it. Just the same as when you're working with a client that may have a language level or be not a native English speaker, you know that sometimes you need to expand those concepts. So because conceptually American Sign Language is different, the way that the interpreter is translating the information, you need to keep in mind there may be some lag time, there may need to be some clarification needed, and really pay attention to your gut and your instinct if you feel like the information isn't being understood in the way you're asking the question. And we're going to talk much more about that today. Jesse, we're talking a little bit about, oh, go ahead.
Hello, everyone. When you have a client in your office, try to make sure that you're talking directly with the deaf client, especially if you have an interpreter present. It's very common that clients don't have general awareness specific to the terminology that we typically use daily, on a daily basis in our practice. You know, for instance, relapse. A client may not be aware or has never heard or been exposed to that term before. So we have to make sure that we expand upon various concepts to make sure that they understand the meaning and context behind that. What does relapse look like? The person potentially even like sober living or things like that. Maybe you could say like they are sober and then they start using again. So you have to really consider what does relapse truly mean and these other concepts. They have to know the context and meaning behind that. And that's our responsibility as providers to be able to provide that meaning and context that's associated with the sign through the interpreter. Also, another concept that typically people, deaf clients in particular, struggle with is the idea of higher power. You know, what is higher power? And so we need to be able to use examples for those clients. So something that you have faith in, something that helps us make it through those tough times in our lives, and something that we can depend on completely. And so often, deaf clients don't necessarily understand that that's really how that works. So it's very important that providers expand on concepts, especially like, for instance, higher power, or even sponsor. Sponsor is another example that you might see people struggle with, because there can be different words that might be associated with that. You know, like, is it a business sponsor? Like, what is that? Of course, we're not using that in the typical context. Within recovery, we use it in a different way. We have to say somebody that helps you through the program, whatever it might be. So we have to make sure that those concepts are clear. And it can take a little bit more time to work through, for instance, the 12 steps. So that way they understand what is a sponsor, how does a sponsor associate with the 12 steps, and they get the meaning behind that. There are other concepts where, for instance, clients maybe don't necessarily understand the full meaning, like clean, like to be clean, right? That will require more expansion. That would be like, don't use a substance, such as drinking or drugs. It's very important that we as providers support the clients with their understanding of these various concepts.
Mm-hmm. Great. Thanks, Jessie, for that. And one thing I wanted to add in terms of some of the terms, we're going to be giving you some examples of step 1 this week and how to make things more visual. And then in our subsequent trainings, we're going to talk a little bit about step 2 and 3. And one of the things with step 3, as Jessie was mentioning, higher power is such a complex issue. And for many deaf individuals who maybe grew up in hearing families, they think of the word God or higher power as meaning the same thing. And they may have been in a situation where they would go to church and there'd be no interpreter, no communication. They would just be sitting there. So it may not be a positive kind of experience for them. So a lot of care needs to be taken in talking about all the different ways higher power can be used, and that it isn't only just a religious connotation. And I'll share with you in a subsequent webinar some examples of how that looks visually for some of the clients that we've worked with. The next thing we wanted to talk a little bit about, and it kind of goes in line with American Sign Language being visual and some of the health literacy issues that we see within the deaf community. If we think about health literacy, we're really talking about how people get information and understand health information and the services that go along with that, so how they make appropriate decisions related to health care. And there's been some research done, as is shown on this slide, that really demonstrates the association with low health literacy and health disparities among deaf people. Deaf people are really more at risk for having low health literacy. So if you think about just reading and writing, beyond that is the skill and knowledge to know how to make the most use out of your health care and optimize it. And it does require having the ability to analyze that information. For example, think about when a doctor prescribes medication, understanding the directions of how to take that prescription, how to understand how to read what's on the label on the prescription bottle, getting an appointment slip, or when you're meeting with a counselor, understanding consent and confidentiality. There's a lot of English and literacy that's really required. Now, we talk about with deaf people the average reading level being below that of 12th grade, and in fact, some research over the years, although it's disputed, talk about 4th grade being the average reading level of many deaf individuals. So if you think about that, and you think about all of this health information and how complex it is, that can be a challenge. So there's a lot of misunderstandings potentially that can happen. Plus, as we've talked about, American Sign Language is structurally very different than English and very visual. So it's really important for us to keep that in mind and expanding concepts and not assuming that certain terms are understood clearly. Access is really key. And so if you look at the next point, if you think about limited access to sign language interpreters, lack of exposure, think about radio. A deaf person doesn't have that exposure. Or conversations that are going on around you, incidental kind of things that happen, families and talking at dinner table, media that doesn't have captioning. And even if it's captioned, maybe it's at a higher reading level than that person needs. So therefore, that information is not accessible. So we really need to work on developing materials for deaf people that take into consideration English literacy, ASL usage, and these issues around really the fund of information. So most deaf people who go to schools for the deaf aren't with their family during the week time. They're with their peers. And so frequently they're learning information from their peers. And we know that that's not always very accurate. So we really need to help to make sure that information is provided in an accurate manner. Only about 30% of information that we say out loud is able to be lip read. So I think there's another misdemeanor that people are able to understand what a hearing person says just by lip reading. And I think we really need to keep in mind that that's not accurate. If I say the letter P and I say the letter B and you're looking at my lips, it looks the same. One of the resources we've included for you today is a chance for you to really look at a video that shows to you how challenging it can be for a person who's really dependent just on lip reading. So we need to keep in mind, as it says on the slide, adding captions is not always enough. If I'm a person who has limited English reading ability, trying to keep up with captions, going the same speed that something is visually, is challenging. Turn on the captioning on your TV sometime when the news is on. And try and imagine that that's what you're focused on doing, and you read at grade level. Then imagine that you're a person with more limited language, English is your second language, and try and think about getting all of the information around you that way. It's very challenging. A couple other points about literacy that we need to keep in mind is that the lack of information that's provided to the deaf community can contribute really to increased hospitalization due to preventable ailments arising in unmanaged chronic conditions and a decrease in routine healthcare screening. So research really has shown us that limited health literacy skilled people are more likely to skip important preventative measures. So health literacy has a direct correlation with individuals tending to go to the emergency room, go to urgent care. So they're geared towards treating complications rather than trying to do treatments to prevent those incidents from occurring. So studies really show that this has a higher rate of hospitalization and all of those kinds of things that follow when we're looking at low health literacy rates. So this whole negative potential health outcome arises in part from what I've talked about, the reduced incidental learning, the lack of information and knowledge that deaf people are able to have access to. So what we really need to do is make more things accessible through visual means. And there are some limited prevention materials out there that the University of Rochester has completed. They had a grant years ago with the Center for Disease Control where they took health-related information, diabetes, asthma, and they did in-depth explanations in sign language. So videos were available on the internet. And so people were able to, maybe for the first time, have a better understanding of some of these diseases. We need to be doing the same thing related to addiction, related to mental health, related to other kinds of behavioral health care issues, if we really expect people to have a full understanding of the role they can play in staying healthy.
as you can see, am a deaf person. I'm able to provide direct communication to my clients, and that's of extreme benefit for them through their treatment journey. However, there are not a lot of deaf people or providers who know ASL, and so you have to use interpreters through those sessions. If you have a deaf consumer who comes in to the room, usually they're outnumbered, correct? Because you have 2 hearing people in the room and then just 1 deaf person. So it's very important that you make a person feel welcome and through the use of the interpreter, and to make sure that it's open communication facilitation of all information. Also, you have to understand that the deaf community is quite small and everyone knows everyone. So it's kind of like the same thing as high school, right? And the same type of feeling that there's a lot of interconnectedness through that community. And so really it's important that you emphasize that the session is completely confidential, completely private, and that anything that is shared during the session stays in the session, and it will not be shared with anyone outside of that room. Oftentimes, interpreters will know the client ahead of time from other community appointments or other community events, and it's very helpful if you allow the interpreter to really emphasize that confidentiality will be of utmost importance. It's also helpful if you can conference with the interpreter prior to the session to debrief with them about the role in the session and what the expectations are of the interpreter during those sessions and how they can stay in their role. That will be very helpful to establish clear boundaries and help the client feel more at ease and will be more willing to share information.
Thanks, Jessie. I think it's absolutely critical to see what the deaf perspective is of someone in treatment, because as hearing people, we don't know what that experience is like. We experience what's called hearing privilege. We just assume that we're always going to have access to information and to services in our direct or our best language. So thinking about what that perspective is and consulting with individuals who are deaf is absolutely critical. We also have to be careful when we put in place language access when there are not staff who sign. In Kentucky, we only have 2 regions of community mental health centers who have therapists who sign, and that's New Vista and Centerstone. For the rest of the state, we rely on interpreters, and we want to make sure that we have qualified interpreters. The way that we set this up was that we wanted to make sure that everyone in the room knew that just having the interpreter present is not enough. So we'll go more into detail about the interpreting next session, but some basic things for you to know. It's really important for you to have contracts in place before you need the interpreters. You don't want to have to call somebody because an individual just walked into your facility for detox, or because you know that you have somebody coming in. Establish contracts, know who you're going to use, provide some orientation to those interpreters on what's expected so that you have a relationship before it starts. There's 2 primary ways that you can get interpreters. One is through freelance, which means they individually contract, and the second would be an interpreter referral agency. Generally, you're going to pay more if you have an interpreter referral agency, but they generally know who the interpreters are in their area, and they also know the deaf community, so they can help you to make a good match between the interpreter and the individual. Not all interpreters are qualified at, skilled at, or comfortable interpreting in substance use settings, and so sometimes those agencies can help you figure that out. It's really important for you to budget for access. So going the free or cheap route is generally not going to be your best rate. You want to make sure that you're getting qualified interpreters, or the excellent services you provide to hearing people will not be fully accessible to people who are deaf and use sign language interpreters. Jessie mentioned comfort level and the idea of the fear that people might have coming into services. Often, because it is a small community, they already know the interpreters in their area. So an individual does have the right to request a preferred interpreter, but they should never be asked to bring their own interpreter or to use a family member. It's really important that you use qualified, licensed interpreters, and that if you have to get additional information through family or through someone else, they're allowed to be in that role, not having to do a dual role of family member and interpreter. We know that there are a lot of specialized skills and vocabulary that are needed in recovery settings, so making sure that you have a qualified licensed interpreter will help with that. And sometimes, just like we have health literacy issues, we also have English literacy issues across Kentucky for hearing and deaf individuals. There also are people who are deaf and aren't fully fluent in English or in sign language, and that's called having language disfluency. So sometimes you have to use what's considered a CDI, a Certified Deaf Interpreter, or a deaf interpreter to help conceptually with that. It's very difficult to get deaf interpreters, so we now have our first deaf certified peer support specialist also available. So you may be able to use a certified peer support specialist, a deaf individual who has gone through recovery, who is living life in recovery, who can help bridge that cultural and communication. So there's a lot of layers to consider when you're working with somebody who is deaf and needs access to effective substance use treatment.
So in terms of developing trust and rapport with clients, that's pivotal to do during intake and all those screenings. That's really the first place that you want to have that with deaf clients. For intake screenings and evaluation, we typically have the counselor or therapist or counselor, an interpreter, and if you can, have a deaf interpreter, certified deaf interpreter there. That way, the language is presented in the most native form to those clients. After the intake screening, potentially, or rather during the intake screening, there can be some potential for misunderstandings. Potentially, it's not always the interpreter, but sometimes it's the language that we include in those intake screenings that, like for example, if you ask a client, how many times in the past 30 days have you drank or used? A lot of times clients will say, what, 30 days? No, I don't understand the question. And that's where you will really have to expand upon that question and potentially make it so that it's a bit clearer and provide a more conceptual timeline. For instance, if I said to a client, okay, in the past month, that's 4 weeks, right? Well, how many times have you drank every week, right, or during the week? Is it 3 times? Oh, okay, that's 3 times. Okay, well then 3 times means if that's a weekly thing and there's 4 weeks, then we do the math on that. How many times is that? Then the client goes, oh, okay. So you have to make sure that you give them that opportunity. And so we might say, okay, you drink 12 times out of the month, or 12 days. That's an example where you might have to expand upon a question that might be a bit vague. How I adapt that is through expanding. I also might role play, like for me as a deaf person, if I have an interpreter in the room, I might have to say to them to essentially role play and demonstrate what's happening in order to help clarify the understanding and to make it better.
And I'll add to some of what Jesse said. I think he gave some excellent examples. The element of time can be very challenging, a day, a week, a month, a year. So always being as visual as possible. And as Jesse said, expansion is key. Using a calendar, talking about if the weather was hot or cold, any way we can come up with to make sure things are clear. And the one other thing to add in terms of developing trust and rapport has to do with confidentiality. I think it's really important as we talk about the deaf community. We've talked a bit about last time the grapevine. And because there's so few specialized treatment programs, one of the things that happens in programs such as Jesse's or in Minnesota is people may end up in a treatment program, and this can happen in Kentucky as well, with people they know that they may have used with. deaf people have not necessarily experienced groups, and we know that treatment is most effective in group settings where we can learn from each other. So oftentimes I find that you have to teach what a group is, what confidentiality means, or that becomes sort of the excuse that some clients will bring into that group experience because they're afraid that other people will leave and tell about what they shared in group. So clinically, setting that up ahead of time, being very clear about confidentiality and group rules, even beyond what you might do in your everyday kind of group settings, is really key. What I wanted to show you now is an actual example of somebody who didn't have an interpreter and attempted to do an assessment in writing. We do not advise this, and I think as I go through this, you'll see why not. You now have learned that ASL is conceptual, it's another language, it's not the same as English, and so some of that will come across as you look at this assessment. But we really want to caution you, advise you, strongly suggest that you never do an assessment in writing such as this example, that you always go through the means that Michelle talked about in Kentucky and have a sign language interpreter that's qualified. So in this example, the first question was, what kind of drugs do you use? And the individual wrote pot. Do you use it every day? Sometime. How much a day? I don't know. How much money you spend a day on pot? I can't remember how much money. Do you think you smoke 3 joints a day, 6 joints, maybe more? 3 joints a day. When was the last time you smoked? Today? I don't smoke today. Do you use any other drugs? Alcohol? Only pot and beer. Now it's important to keep in mind that when we do any kind of expansion, for a question that says, do you drink alcohol? We go through the expansion of that means beer, wine, vodka, whiskey, mixed drink, because oftentimes people think beer and wine aren't considered alcohol, that only the definition of hard alcohol is alcohol. So we do a lot of expansion. So in this case, a little bit of minimizing, only pot and beer. How much beer do you drink? Every day or only weekends? Both, sometimes not drinking for 1 or 3 days. When you drink beer, how many do you drink in one day? 2, 4, or more? I only buy a case in one day. You mean you drink 1 case in one day? Not all beer, just till I got drinking and stopped. Do you have any medical problems? Do you have medications that a doctor gives you? Yes, doctor gives me a pill and it makes me sick. Do you know what kind of medication? Called what? It's hard to spell. When was the last time you smoked? Today? I don't smoke today. What was the medication for? The doctors say it will help me calm down and make me not so sad. So I think, again, we need to keep in mind that we want to steer clear from using writing to try and do an assessment to come up with a diagnosis. The person who was doing this assessment did not have the ability to expand on any of these concepts, get any other information, and really could cause a lot of harm as the person leaves this assessment with you not knowing all this information, the medication they're taking, what else they might be doing as they leave that office. So please be sure and use a certified sign language interpreter for any kind of assessment with a deaf client.
When a deaf client comes in to work with a hearing provider like yourselves, they typically will feel very isolated because everything around them is hearing people. And even in groups in particular, when we have a group where there might be a counselor who's trying to do some sort of activity through group therapy, a lot of times deaf clients will often feel, again, isolated because there's no peer to engage with. So they need that relationship during group. In that way, they will feel supported. But a lot of times that doesn't happen. Most of the time, they will feel isolated and detached from the group. With groups, sometimes there might be, let's say, for example, 11 hearing people, 1 interpreter, and the hearing provider, and then just 1 deaf person. Typically, when that happens, a provider might expect that the deaf client be okay. They might just say, well, I'm not going to ask them any questions. I'm not going to force them to participate in group discussion. Or perhaps they don't want to hassle them, and there might be a little bit of a lag or delay through the interpretation, so that might also mean that the provider will try to skip them. So it's really imperative that you make sure that the deaf person feels involved with any sort of group or group therapy. You can ask them how they're doing. How are you feeling today? Have you been keeping clean and sober? Just simple questions will make the client start to feel more welcome and more engaged with the group. So it's very important to do that. Also, as a warning, a deaf person will often use the deaf card, quote unquote. That's what we would call, like, in a sense, our way out of participating in therapy. A lot of times deaf people will do that because maybe they don't understand the interpreter, or they don't understand the question or the topic at hand. And so really often they will play the deaf card in order to get out of something. And basically that's the idea of what's happening there. So make sure that you do not allow them to use that as a means to get out of any sort of therapy. Also, hearing people in groups will often become very fascinated by the use of an interpreter and the use of ASL, and I see that happen with providers and counselors too. So it's really important not to let that happen and to just remain on task of getting people to participate in the discussion and the conversation at hand. So sometimes that can make a deaf person feel very, much like they have a lot of eyes on them. So it's really best to encourage people to make sure that it's a little bit more of a natural conversation and that there's a natural flow to conversation. In large group settings, a deaf person will often feel like they don't have that trust and rapport with the group, and they may not have that trust with the interpreter, and so they might also have a distrust that the interpreter is saying everything correctly. So it's really important to keep a monitor of what is going on between the interpreter and the deaf person during group. And in my experience in group settings, when it's been all deaf people, is that we have various levels of education of those involved, various backgrounds, and various upbringings. So essentially it's not a homogeneous group. And I typically will kind of poll everybody and poll our clients to just kind of determine their level, if you will, and where are they in their level of communication and comprehension when I decide to, in terms of how I decide to approach the information. So I will try my best to gauge that. Like, for example, I might have one person in group who will have no literacy skills and no English proficiency, and they might only have a basic understanding of ASL. And then I might have another person in the group who, might have excellent literacy skills and completely understands the concept of communication and utilizing ASL. And so that's where it can get a little tricky, is if you have differing levels. And oftentimes, the person who has that high level of language skills maybe will sometimes try to help clearly explain for the person with lower language skills. And so that's why role play can be very useful, where everyone can be able to be involved in the group. It doesn't rely heavily on one, means, and that can be, a way to help engage the group in group therapy. Because an interpreter in the group cannot be expected to participate in the group. So really it's good to ask the client if they understand, are they following, and make sure that they're following the group discussion. You want to make sure at the end that they all feel included, and make sure that you engage them in that group therapy. Active listening skills are very important. And so you have to make sure that you ask questions often, and sometimes you might need to rephrase questions or rephrase, essentially mirror back to them what they said to make sure that communication is clear. That will also make the client feel like they are heard and increase that trust and participation in group. For my program in San Diego, we use a lot of role play, and we use it often. We also often use cards with simple questions on them. And then we'll pass them out in the group, and each person gets a card. That helps them also feel like they are part of the group. So they get to pose the question and the response. And so that is also a very successful strategy that we use.
Mm-hmm. That's great, Jessie. Excellent examples. I think those are things that people can take with them even in the settings that they're working in currently. Just a couple additional comments in terms of lag time. And if you watch right now, you can see that when we're talking and the interpreter's signing, she may still be signing after we finish the last thing we've stated. So imagine if you're doing a group. If there's a discussion going on and you have a deaf person, they may want to add something, but the interpreter hasn't finished the signing, so they're not able to do so. And if you're not aware of that, then you're on to the next comment. So turn taking in a group is really important. And I've seen people use, even in all hearing groups, different kinds of tools where a person holding an object has the turn to talk, so having objects that are passed around when it's someone's turn, but really being aware of different strategies that you can use in a group to make sure that everyone's able to participate equally. The other thing regarding the whole deaf card concept, most of the clients that I've worked with have been in multiple treatments, some hearing treatment programs, some deaf-specific programs. And I mentioned the first training, the police officer example, where it's very easy to caught up with thinking, oh, because a person is deaf, they don't do anything wrong. They're nice people. Well, we're all nice people. It doesn't mean we can't be an addict. And so it's very easy in some situations because of being caught up with, oh, this is so cool. We have a deaf person here in the treatment program, that they don't have the same accountability. So it's really important to remember that regardless of deaf or hearing, the person's there because they need treatment, and they need to have the same expectations. You need to make sure the information is accessible, yes, and try and figure out ways to make sure that occurs. But in the end, an addict's an addict. So keep that in mind as well. So because the whole concept of deaf culture can be challenging, it's a whole new concept for many of you, we wanted to share with you some different resources that you could access online. So here are several different resources where you can learn more about deaf culture, deaf community, American Sign Language in accessible ways. So there are different links here. 3 of them relate to being videos, and the last one is a book that you can read if you're really interested in getting more information. I'd encourage you to do that. Michelle.
So a concept that I learned about recently when working with especially people who are hard of hearing is called the belt and suspenders approach. And it's the idea that we want things to be simple. We want there to be one way that we're always going to do this. Like, I am always going to call an interpreter and that's going to solve every problem. That's not really how it works when we're working with the deaf community. Every individual is different. Everyone has different language abilities, has different cultural pieces to consider. And so the belt and suspenders approach is the idea that you bring all the tools to bear that you possibly can. You employ multiple methods or procedures to achieve your desired result, including sign language, role play, visual strategies, having backup information, utilizing other group members who might have a concept down to teach somebody else, which Neil Glickman refers to as the one down method. So it's really important that we bring to bear all the resources that we have, and that's considered the belt and suspenders approach. We are starting to run out of time, so I don't want anyone to feel like we're going to miss information. The PowerPoint will have many slides towards the end with resources for you. So for those of you engaging in working with the deaf community for the first time, it can feel very overwhelming, but we are going to give you many resources that you can check on your own so that you can think about and study this in between our sessions as well. And you can feel free to contact us between webinars if you have questions as well. So I'm going to pass it back to Deb.
Jesse, go ahead.
In terms of 12-step meetings, typically those are inaccessible for everyone, and that's a nationwide issue that we see, especially in various communities. To have a 12-step meeting with an interpreter, like for example, in Minneapolis and Rochester, New York, and Austin, Texas, and potentially Vancouver, Washington, as well as here in San Diego, there are some that are accessible, but a lot of deaf people do not have access to interpreters for 12-step meetings. That really does not make recovery easy for deaf people who live in other areas where there might not be accessible meetings. Also, for a deaf person who is in recovery and wants to stay in their home community, oftentimes there are issues because they might know other people in that community or deaf people who are still using, or potentially they know other people who are not supportive of their recovery. There's a big stigma, a negative stigma, which is a huge issue for the deaf community when it comes to substance use. So it's a very serious issue that they have. So if somebody is addicted to drugs or has a drinking problem, a lot of times the community will break away from that person and not be around them because of that common stigma in the deaf community that a person essentially cannot be successful in recovery. And so, or even if somebody says, hey, I'm in recovery, a lot of times the deaf community doesn't understand that. And that centers around education and just understanding what that deaf person is going through. So a lot of times they are not provided enough support. That is a big struggle for deaf people in other communities where there might not be as big of a deaf population. Also, it's important that in deaf communities, there's no access to, for instance, Al-Anon meetings with interpreters where their loved ones can go and learn about how to be more supportive to that deaf person in recovery. So that resource typically is not available. And also, a deaf individual may come from a deaf family. Potentially their parents are deaf, or have an aunt or uncle or cousin, sibling, whoever that may be deaf. And they may want them to be a part of the recovery and to get their support, but unfortunately the family might want to provide that support, but unfortunately they don't have access to learning about those resources in order to be a better family member, better family support and a part of that recovery process. So that's another problem. Also, with an ASL interpreter, potentially they have not been in recovery themselves. Oftentimes, interpreters have not experienced recovery, and that can be an issue, especially like when it comes to closed meetings. For instance, with alcoholics or those who might have a drug addiction, they don't usually allow outsiders in, and so sometimes members of the meeting will complain that, hey, the interpreter is not a part of this, they're not a member of our group, and therefore we don't want them in this 12-step meeting. So we often try to find interpreters who are members of 12-step groups and have experienced recovery in order to interpret those closed meetings, but it can be a struggle to find them. Okay, Jen, back to you.
I think we've really talked a lot about information to keep in mind in terms of best practices. And I think that it's key when we're talking about specialized treatment programs that the staff have knowledge about deaf culture and that they're fluent in sign language, and that those programs really focus on having a reduced emphasis on reading and writing, and use, drawing and role play and other visual techniques as much as possible. And whether it's a specialized treatment program or it's a mainstream treatment program, access is key. So at some point, Michelle can talk with you about if you are providing treatment services in a residential treatment program or an intensive outpatient kind of program, it's important that people have access to having video phones available, which are provided at no cost typically, or that there would be a flashing light system. So if it's a residential treatment program and someone has their door shut, obviously they're not going to hear if someone knocks on the door. But if there's a flashing light system, then they would know that someone was at their door, or for alarms for fire code, etc. So there's a lot of ways you could have access without a lot of cost involved, and obviously it's important for not just for emergency reasons, but also comfort level and having things be equal for that person. And as we talked about, some of the things that really are important in these kind of treatment programs is making sure that we modify materials to meet the needs of the client as much as possible. And we're going to give you some of those examples in a couple minutes here. So when we talk about treatment programs, most of you are following an evidence-based treatment model. So we have a couple different ways of looking at treatment models. We have evidence-based. We know that that's research showing that that's effective in helping people. And then we have more what we call a promising model. And that's something that maybe doesn't have full out-and-out research documentation, but we know that given long-term use and given the documented outcomes, that it looks like it is leading towards being evidence-based model. And the program in Minnesota that we've talked about, and I'm going to give you a couple examples of some of the work done by clients, we would consider a promising approach or promising model. And I've put here the website that you can go to where there's a lot of materials available and articles, visual materials, curriculums. I think you'll find it useful. So a couple of the examples that I wanted to share with you just focus on some of the work regarding making the 12-step materials more concrete. As we know, there's a lot of terminology in the 12 steps that are difficult for hearing people, not only for deaf people. And so in Minnesota, when the program first started, we tried to figure out how to take those very abstract concepts and make them as visual as possible. And one of the approaches that we found effective was using drawing. And whether you have a person who's graduated from college or hasn't finished high school, what better way to make the playing field equal than to use drawing? And you don't have to be an excellent artist or an art therapist to use art in treatment. And actually, the approach was first used with a number of clients who were hearing and inhalant abusers. And they had so much difficulty focusing that they had started to use artwork very effectively with those individuals. And we took that concept and built it into a model that we found to be very effective. Today I'm just going to show you a couple examples of our drug chart work and our step 1 work. But the way that we break it down, in the drug chart, we basically talk about gathering information in terms of drugs the client has used, when they used last prior to treatment, and consequences of use. Those are basically some of the things we try and do when we're gathering information in a visual way. In terms of the step work, I've just given some examples of how we break down into the primary concepts of the steps that we try and get across through the use of drawing and expansion in other ways. So for instance, in step 1, we focus on powerless and unmanageability. Step 2, we really try and focus on the hope and help step. Step 3, more an action step where we focus on higher power and getting strength from somewhere else other than yourselves. And then we go ahead with the inventory in step 4 and 5. Most of the time in Minnesota, the clients, we get through probably step 3 before they leave treatment. We aren't always able to go beyond that. So I'm just going to show you a couple examples actually of step 1 today and the drug chart. And then if you find that interesting, if you come back next month or beyond, you'll get to see a few more examples that I have. So this is an example of what the drug chart might look like. Again, if we're working with the client with very limited language, this is too much. We wouldn't put this all up at the same time. But you can see that we've broken down the concept of consequences to mean when I'm high or drunk, bad things happen to me. So that's how we explain consequences in case a person is confused about what that means. And then we really talk about the various body and consequences that happen in our life areas. So we start with the body consequences, financial consequences, family, legal, job or school, and social. So we might assign a client to draw 3 pictures of each one of those. We might ask them to draw 1 picture. It really would depend on the client. And this is just one very small part of, obviously, the treatment experience. So I have a couple examples here. This picture was drawn by an individual who had no language. He became deaf from ear infections that were untreated. He lived in a very rural and isolated setting. And so the way that we gathered information from him was the fact that he could draw the shape of the bottle or container or item that he was using, and staff helped him to label it. So if you look at the first picture, the staff labeled it as basically a wine bottle, the second item as the beer can, the third as a whiskey bottle, and then a joint. And so we had to gather all the information from that client using this kind of approach, a lot of role play. Staff would actually bring them into the community to a store where they sold liquor and where they sold non-alcoholic beverages and shake their head yes as they would go through water and soda and different things that were not alcoholic, and shake their head no when they went to beer and whiskey and wine and items that he chose to use. So you can see where we tried any means possible that would work with this client. And this individual actually, we know, maintained sobriety at least a year following treatment. He did relapse. He did come back. The situation he lived in was dire, but he learned from this. And you are able to use this approach to really teach concepts to people that otherwise would not have success in a traditional program. Here's a brief example of someone who has, obviously, they're bleeding, so they have a physical kind of consequence, and that's just a couple examples of the drug chart. If we look at step 1, I'll show you a few pictures, but again, in here, the concept is unmanageability and powerless. So here's an example of a person who's powerless. If you look at the divide in the road, going one way, you see a bar. Going the other way, you see a movie. So making the choice to go the good way to the movie or the bad way to the bar. And unfortunately for this person, he feels he chose the bad way. And so you can see there's some writing here where he talks about going to that bar and getting drunk. And that was part of his step 1. Here's another very descriptive drawing of powerless, where if you look on the road signs, you see beer going one way, and you see party going one way, and you see everything in the negative direction, and then you see sober or good way the other way. And this tug of war, which is so perfect for an example of what is experienced by people, the tug of war between wanting to be sober and the struggle of wanting to use and how you're going to defeat that. So you can see where drawing can really help all of the clients who may have some limitations with language understand and make the concepts more concrete. We're running out of time. Just very briefly, a relapse prevention activity that we use that, again, is very, very visual that I think you could use with any of your clients. We have them, again, do a lot of drawing. And for this activity, I'll show you what it looks like first, this map. So you see this map. And we have triggers and we have solutions. And the way we have people think about it might be you're in a boat on the ocean and you hit a wave and you want to avoid capsizing. So what are some of the strategies you use so that you don't go overboard on the boat? And we look at relapse in that same way. You're going to go along your path, things are going well, and then something's going to happen, some kind of a trigger that makes you think about wanting to relapse. What helps you get through that? So this is called a relapse prevention map, and we have the clients use different colors, as I mentioned down below, be creative, and come up with their own plan of action to help with their sobriety. So that's the end of what we had prepared today. I've listed here some resources. If you're interested in hearing some recovery stories from deaf people that are in sign language and captioned and voiced, we've listed 3 different stories, Marco's story and then 2 parts to Bobby's story. And we also have some other literacy resources if you're interested in more information on research done on health literacy. And then, as we mentioned, an activity where you can experience what it's like to try and lip read. And I'll turn it back over to Michelle at this point, I guess, or Jesse, if you have anything to add.
This is Michelle. Thank you so much, Deb. I know we have so much more information to share than we can possibly fit into a 1-hour webinar, and I really appreciate all of the time you put into giving us those visual examples. It's easy for those of us who work with the deaf community to think about how to make things more visual because we do it every day, but that can feel a little bit awkward for people who may not be used to that. I think in addition to having a qualified interpreter, I know I can't do my work without having a dry erase board and something else available. So I know we're a little bit over, and I appreciate those of you who are able to stick it out with us. One of the questions that we did have was how often do people use signed exact English or pidgin signed English, and how does that affect getting an interpreter? That is a great question. Neither Pidgin Signed English or PSE or Signed Exact English C are actual languages. Both of them are codes, but they are not languages. American Sign Language is a true language. So if you have a person who uses either C or PSE, you'll need to work with them to figure out what's going to work best. Often they will use an American Sign Language interpreter who's going to do what we consider signing more English. But that really varies. And next session, we will be going into how to obtain a qualified sign language interpreter. And I think we'll be spending some more time on great examples of how Jesse and Deb have adapted their materials while working with an interpreter as well. So there are a couple of things that we were going to ask you all as we wrap up. And I see I have one answer so far. Which recovery concepts do you plan to adapt so that they're better understood by deaf individuals? And this looks like the response is pictures and drawings is how you're going to adapt it, which is great. But just a reminder as we wrap up that many of the concepts and the vocabulary words that we use are not easily understandable by people who are deaf who are new in recovery. So I think that's a key piece that we would like you to leave today with. And as you think about recovery strategies, absolutely the recovery plan is important. And I think Deb gave some good examples of how can you make that look visual. We had one person in Kentucky who did an amazing visual of their recovery plan, and they made it cover an entire wall, and it was steps, like literal steps. And we put it up in their apartment and then took pictures, and when the person came in for treatment, they showed me a copy of their picture and where they were on the steps. And sometimes they walked up the steps and sometimes they walked down the steps. It just varied on how they were doing that day or that week. And as somebody answered already, it's very critical to stress confidentiality to develop the trust and rapport. One of our biggest concerns is that if people come in to a hearing provider, they've dealt with discrimination, they've dealt with oppression, and lack of access for a long time. The most important thing we as hearing people can do is to show and develop trust and to work to develop rapport, to have cultural humility, and to provide language access. And so I want to leave you with those thoughts as we wrap up today's session and hope that you will join us in our third session next month. We also will be sending you links to both the first webinar and the second webinar. And we encourage you to invite others to join us. It's important that we build a network of providers who understand the cultural and the linguistic accommodations that are necessary. And absolutely that confidentiality is important, I see someone saying, and then making every attempt to make a person feel comfortable by trying to find out what we can do, because it is our job always to meet the client where they're at and to adjust. I want to thank the people at C4 Innovations for being our behind-the-scenes folks, moving our different pods in our room today and encouraging us to get our information together. I want to thank Jessica Mingus, our interpreter today, who's done a great job, especially with freezing frames and lots of things happening. And especially thanks to Jesse and to Deb for sharing your wealth of information. So